Welcome. I'm John Zvribik, former Chief of Mental Health Services at the Joslin Diabetes Center in Boston. I'm delighted to introduce Dr. Ann Goebel-Fabry, who was a psychologist at Joslin for many years and is now in private practice in Brookline, Massachusetts. She's an internationally recognized expert about eating disorders and diabetes. She's also the author of the acclaimed book, Prevention and Recovery from Eating Disorders and Type 1 Diabetes, Injecting Hope. I want to let you know that she'll be taking questions for a few moments at the end of this webinar. So if you'd like to post questions, do so through the Q&A box at the bottom of your screen. So now, based upon her research and clinical experience, Anne will now give us some insight into how to manage this very difficult problem.
Well, thanks a lot, John. And thank you very much. I'm not seeing my face, so I don't know if you can see me. Oh, there I am. Okay. This is just such a strange concept. Well, welcome everybody. Thank you so much for coming to this mini course. I'm going to emphasize the concept of mini. I've never given a talk quite this short before on such a complex phenomenon. I like to start by grounding people in the two primary diagnoses for eating disorders. The first is bulimia nervosa, and this is a condition that shares a common foundation that both eating disorders have, which is that in both cases, people with these eating disorders base their self-esteem on their body shape and size, and specifically on their weight. In bulimia nervosa, we're talking about symptoms of recurrent episodes of binge eating, which has a very specific definition, a larger amount of food than one's peers would eat under similar circumstances. And it's accompanied by a sense of loss of control over eating. This then gets triggered in terms of compensatory strategies with recurrent purging to try to prevent weight gain. Purges can include self-induced vomiting. They can include misuse of medications like insulin in our case, and can also involve fasting or excessive exercise as a strategy to try to prevent weight gain. Anorexia nervosa, again, these are people who base their self-esteem on their shape and weight, but in this case, they have a disturbance in their perception of body weight and shape. They have an intense fear of weight gain despite being underweight, and in fact, misperceive their body size as being overweight. They then engage in very severe symptoms of food and calorie restriction, which leads to a less than minimally normal body weight. When anorexia nervosa happens within the context of type 1 diabetes, the food restriction that these patients are engaging in can actually result in recurrent low blood sugars and or low A1C that's either at target or below target A1C. And these patients often will get encouragement and praise from the healthcare community for having such well-managed diabetes. And this can actually mask the fact that they have an eating disorder until their BMI becomes dangerously low. So most of the research and most of the patients who have eating disorders in type 1 diabetes often engaged in insulin restriction as a calorie purge. So why would insulin restriction be a calorie purge? Well, without insulin, the body can't absorb glucose from the blood. It can't use or store those calories. It in fact attempts to regulate blood glucose the best it can through glycosuria. So weight is also lost. The calories are being excreted through urine. cells are starving. They turn to fat and muscle stores for energy. Ketone bodies form, and in the worst case scenario, the pH balance of the body can actually change, and this results in diabetic ketoacidosis, which can be fatal. I just saw an article in Diabetologia, which shows that DKA is the leading cause mortality in type 1 diabetes for people below 58 years. So we know that eating disorders are very dangerous and very risky, but why would patients with type 1 have these risks, and what are the risks? Women with type 1 diabetes have almost 2.5 times the risk of developing an eating disorder. So we have to wonder what's unique about type 1 that places patients at this greater risk. We've seen a range of research on insulin restriction, as low as 2% of people endorsing insulin restriction for weight loss, and as high as 40% of people endorsing restriction. So this is a very broad category and hard to pin down. What we do know, though, is that those who restrict insulin and who have eating disorders, that there's a strong relationship with that symptom of insulin restriction and the microvascular complications of diabetes, retinopathy, nephropathy, and neuropathy. Insulin restriction and eating disorders, depending on the research that you read, conveys between 3 and 6 times increased risk of all-cause mortality. And a paper by Nielsen and colleagues showed that when combined with anorexia, type 1 diabetes, there's a 34.8% risk of mortality. So what is it about diabetes that makes it a higher risk group? Well, this is speculative, but this is what people like me have been writing about. We think that type 1 diabetes presents initially, we know, with weight loss, but once blood glucose is regulated, that weight is typically restored. And so in patients who may already be at risk for developing an eating disorder, they may construe this as insulin made me fat. And this is what I hear quite often from my patients. We know that diabetes treatment itself focuses on food content, on portion size, exercise, and weight. And by combining all of those as such a profound focus can actually mirror a very rigid eating disorder mindset. It can result in feelings of deprivation and shame over quote unquote cheating on the meal plan. And this can sometimes promote binge eating and secrecy. We also know that intensive insulin management can promote weight gain, as we saw that in the DCCT data. So what's known right now about treatment? As early as 2009, a group of experts were convened to develop consensus treatment guidelines. These were guidelines that were based not on actual research in type 1, but on clinical experience and on eating disorder research outside the area of type 1 diabetes. Early treatment outcome studies looking at eating disorders and type 1 were characterized by being small, less than 40 participants in each study, rarely having comparison groups or follow-up, and were hard to translate to the US population, where Takie et al. Did an inpatient study of eating disorders and type 1 in Japan, but their mean inpatient stay was 4 months long, and this is just not the way that American healthcare works. Studies did show, however, these 4 studies showed higher treatment dropout rates, longer treatment length for those who did not drop out, and lower than expected recovery rates. So what that's led people to believe is that we need a treatment that's grounded in empirical research, but that has in eating disorders, but that has then been tailored to more specific needs of patients with type 1. So here's really exciting emerging research. An eating disorder prevention manual that has a lot of empirical support already, which is called the Body Project, is currently being tailored for the use in type 1 to try to prevent eating disorders in type 1. A small pilot study out of Duke is applying has applied acceptance and commitment therapy tailored for type 1 and shows that they had very few dropouts. They had significant symptom and A1C improvement in a mix of patients. So patients who had both anorexia nervosa, bulimia nervosa, and other OSFED, which is other specified feeding and eating disorders. So it was a mixed group. What they had in common was they had an eating disorder and they had type 1. Now, out in the UK, they're doing a very exciting process of studies. It's referred to as the STEADY study, Safe Management of People with Type 1 Diabetes and Eating Disorder Study. And what they've done so far is they've gotten two research projects looking at what healthcare providers say they need to learn about this population, and then looking at the eating disorder population in type 1 and learning from them what they think their treatment needs are. And now they're going to create a cognitive behavioral therapy specifically for what in the UK is being referred to as TIDE, type 1 disordered eating. Here are some practical tips. And they're really in no particular order. So, but I do think the first one really should be primary, which is that in order to, these patients typically come to healthcare with profound shame and a sense of secrecy. They're desperate for care, but they're terrified of weight gain, and they're terrified that improving their diabetes management is going to result in weight gain. So in order to even have a relationship with them where they will open up about what's actually going on, the relationship has to be based in non-shaming approaches. So no fear tactics, no shaming. People need to practice with themselves. What are their open-ended questions going to be? What are you going to use to try to engage patients around this conversation? So I suggest things that start with, how do you feel about, but you could do anything you prefer, but practice these kinds of questions. How do you feel about diabetes? How do you feel about your body weight? How do you feel about your eating? How do you feel about your insulin dose? And in my research, we've used, do you ever take less insulin than you should, which is a yes/no question that's not open-ended. But if they say yes, then the question becomes, why would that be? And sometimes it is because of calorie restriction, but sometimes it's for all kinds of other reasons. Maybe they're depressed and unmotivated. Maybe they're afraid of hypoglycemia. Maybe they can't afford the insulin. There could be any number of reasons, but to try to get to what's the core issue that's preventing them from improving their health. Remember that eating disorders come in many forms. You're not always going to see high A1C. Insulin restriction is the most common among type 1 patients, but it's not always going to look like insulin restriction. It may be more on the anorexia continuum. Patients are not always underweight. In fact, patients with bulimia who don't have type 1 diabetes are typically average or potentially even slightly overweight. And I think this is sometimes true with what's called diabulimia, an eating disorder involving insulin restriction. So how the person looks and what their weight status is not necessarily going to raise your red flags. Very important in your practice to encourage flexible eating, varieties of foods, all foods fit kind of approach to meal planning, and both within the clinic and within patients' homes, family members, et cetera, to really encourage a no body, no diet talk. So, just not commenting on body size, not commenting on weight. Oh, you lost weight, you look so good. None of that conversation needs to be happening. On the other side, though, it is important to take patients' weight concerns seriously. If they have weight to lose and if they are interested in recovering from their eating disorder and they're afraid of weight gain, working with them around taking a long-range view, gradually losing weight through healthier means, as opposed to the dramatic weight loss that comes with such dangerous symptoms as insulin restriction. very important to help patients identify symptoms of DKA for their safety. Have family members know what the symptoms are also. And once a patient is committed to improving their healthcare and committed to recovery from their eating disorder, A1C should only be lowered gradually. We don't exactly know what gradually means as far as how slowly, how long to take, but we do know that abrupt reduction in A1C can result in what's being called treatment-induced complications, which absolutely we want to avoid. I think the nice thing too, though, about lowering that A1C gradually is you get to celebrate each small success along the way. And I think that's a lesson in decreasing perfectionism, which patients with eating disorders very often struggle with. And I think healthcare providers very often struggle with too. Lastly, as a healthcare provider, pay attention to your own anxiety level. These patients can be scary, they can be frustrating. They're obviously running very, very risky behaviors. Don't worry alone. Seek out consultations, seek out colleagues, and know that this treatment is not for everybody. Here's how to create a referral network. We talk about the dream team versus the real team. So at Joslin, we were very lucky to have a whole slew of specialists that we were a part of. We were embedded as mental health people. We were embedded in the rest of the healthcare team, covered over one roof. That's a luxury that most healthcare providers don't actually have. So you need to develop a referral network outside of your office. It's hard to find an eating disorder expert who also knows type 1, but you can find eating disorder experts who will be willing to learn about type 1 and collaborate with them very closely. This kind of team collaboration requires frequent communication between team members. So I have patients sign off that they agree to the use of phone or email, for example, because it's a way of creating close communication. Potential referral sources. We've got top of the list, the ADA Mental Health Directory. This is an extremely good resource. You've got folks who have already shown an interest in type 1 and type 2 diabetes and have had some training in it. The Diabulimia Helpline and We Are Diabetes are two nonprofit organizations that you can access by the internet. They have advice about referral sources as well, and specifically about inpatient partnerships that they've developed with eating disorder treatment centers that they've actually vetted who do good work with type 1. Lastly, the National Eating Disorder Association is a professional organization like the ADA. It's an organization of clinicians, and you can find across the world and across the country, you can find referrals there. So how do we define recovery? Here's how I define it. It's still a working model, but I define recovery as consistently taking appropriate insulin doses and checking blood sugar, eating with variety, moderation, and flexibility, enjoyable movement, figuring out what kind of exercise feels good and doing that, no extremes in that, refraining from dieting, binging, and purging, and not acting on eating disorder thoughts, feelings, or urges. It's not to say those thoughts don't happen, they will happen, but figuring out coping strategies, what to do about them, and how not to act on them. And I'm just gonna wrap up with a quote from my book. This is one of the women that I interviewed who had already recovered. And she says, there are people that have gone through this and come out on the other side, and they're not amazing people. They're not shiny, happy people. They're just regular people who never felt like they could do it, but did. And I like to end on that note because I think it can feel very hard to be in the thick of this kind of clinical work and not see progress for a very long time. And people need to take a long range view, need to be able to sit on their anxiety, tamp that down, and remain in close connection with patients and with their experience. So recovery can happen, and it does. And now I think we're going to take some questions, John.
Yes, we have a couple of questions, and the first two are somewhat related. The first one, is there a level of A1C that should trigger worries about an eating disorder?
Is there a level? Well, I don't think there's a particular level, but I would say I get concerned if A1Cs are below 6.5, and I get concerned if A1Cs are above 9. And I say that because, well, even above 10 maybe, because I think patients can have mismanaged diabetes for a lot of other mental health reasons and for a lot of other situational reasons that aren't necessarily frank eating disorder. So, anytime A1C is out of target, you want to ask about what's going on in people's lives, and and of course, eating disorder is one of the things to assess for.
Thank you. Here's a second question. What do you do when you suspect an eating disorder, but the person denies it?
Oh, it's the worst. It happens all the time. So it's a matter of readiness, right? It's sort of like if you're a primary care doctor and you suspect substance abuse and the patient says no, it's a matter of readiness. So that's why I encourage those open-ended questions, but not like a targeted question, like you're skipping your insulin because you're trying to lose weight, aren't you? Or you're, I think you have an eating disorder. You could, I give the example that I saw a patient once at Joslin who we suspected had an eating disorder for a couple of years, and all the open-ended questions in the world didn't reveal anything more than, no, I'm flaky, I just can't concentrate on my diabetes, I have other things going on. And ultimately, when she left for college, she Googled me and found that there's all this stuff about eating disorders and type 1. And lo and behold, I actually knew about it. And she came back to me and said, so it turns out you know about this stuff. And why didn't you call me on it? And I said, how would that have worked? You have to be ready. And she was ready then.
A related question from the Q&A. Someone's saying that being non-judgmental is key. I think you referred to that.
Yep.
And they tend to say something like, quote, a lot of my patients struggle with this kind of a problem.
Yep.
Is that kind of language you use? That's something you have ever dealt with?
I think that's great language to use. Yeah. Or I've worked with a lot of people who struggle with, concerns about their weight. Or I work with a number of people who've struggled with worrying about their insulin dose and not feeling comfortable taking enough insulin, things like that.
Before we go on to more questions, I just want to let everybody know that you'll receive an email for a YouTube link to the recording. And the recording will also be available on LinkedIn. And several people want to know if these slides are also going to be available on the ADA website. And that's kind of up to you, Anne. The recording will be available. Do you know if the slides may be available?
I'm assuming so. Yeah,
Okay.
I think so.
All right. Let me ask you this is a more complicated question. I think you didn't say too much about this in the short time that you had. But what would you do about insulin-related edema?
Yeah. So what John's talking about, I left this out on purpose because it is very complicated, but what John's talking about is when a person has been running their glucose very, very high for quite some time, or if they're in frank DKA. DKA is sort of the best example of this. When a patient goes into intensive care and gets onto an insulin drip and their blood glucose stabilizes, they've also been so profoundly dehydrated from the glycosuria and from the wasting that they've been experiencing that now their body actually has a chance to rehydrate, and the body will retain fluid. in sometimes quite large and dramatic ways. And so it can be one of the biggest triggers to relapse is going in for DKA, getting stabilized, gaining what they perceive to be real weight because they feel larger. The number on the scale is larger. It can be about 20 pounds sometimes. And it's their biggest fear, and it's happened in 2 or 3 days. So at that point, I typically will, if I'm starting to work with somebody on an eating disorder and they've been insulin restricting, it's another reason to go slowly and gradually. They'll have less edema if they go slowly and gradually down with their A1C. But I also predict that edema for them. And I say, this is what sometimes happens. And when it happens, this is what people often feel. They get scared. They think it's real weight. They think it's not going to go away. And it does go away gradually. And we know it's not weight. And we'll keep reminding you of that. And we'll keep working with you around that. And that can be sometimes very helpful. And oftentimes people who've had DKA before will say, oh my God, that totally happened to me. And, that's exactly why I left the hospital and immediately stopped my insulin again.
Okay. Hang on a second. I'm just looking at a couple more questions came in. Which is, I have successfully put a pump patient with bulimia and insulin remission on tandem control in exercise mode with a higher target, also extreme fear of hypoglycemia. A1C came down abruptly from 14% to 8.5% in a few weeks, which is a pretty quick reduction. What else could we do if the quick drop is concerning?
The quick drop is very concerning. So I've had some people do that on their own where, or the classic example is a patient who went to a treatment center that actually understood diabetes and treated very, very well and was doing the slow and gradual reduction approach. But this patient was such a perfectionist that as soon as she left, even though she was told to go slowly, boom, aimed for 7. And she wound up with neuropathic pain from her neck down. And it was temporary, thank goodness, but it lasted about 6 months. And I think putting somebody on tandem on any of these sort of hybrid closed loop pumps is very tricky if they're that high. I would say try to work with people going slowly and steadily until they're closer to, let's say, 8%, and then they're safe for that kind of intensification. But I would say from 14, it should be a gradual reduction, like maybe one percentage point a month or something like that. That's what some of the research shows is safer to do.
Here's an interesting question. You referred to the treatment team, and there's a question about eating disorder specialists in my area not acquainted with type 1 diabetes, so I refer them to eating disorder specialists, but they won't consult with me. I do refer clients to an RD clinic that has knowledge with type 1 and specializes in eating disorders. But if the problems become more than I can manage, what else might I be able to do?
Well, I think it's great that you have that the dietitian team is collaborative and working well with you. I would say it's important to maybe if you're having that experience to find out what other eating disorder experts are in the area and to maybe interview them or explain. I mean, especially if people are in private practice, they're going to want to work with patients. They're going to want to have clients, but they're not going to get referrals if they don't collaborate. And if they're not willing to learn about type 1, then they're not safe providers to have on the team anyway.
So there are a couple other questions that we won't have time to answer, but I just want you to know that we have your names and your questions, And we'll send you a follow-up email with answers to the questions. We want to thank you for attending. And do you have any final words, Ann?
Just thank you so much. I appreciate people's interest, and there's so much depth to talk about with this population. I'd welcome a chance to do it again.
Thank you very much for your inspiring talk in such a short period of time.
Thank you.